I hope we are audible enough for everyone. Thank you for joining us for today's session. At this point, I would like our hub team to introduce themselves. I will start from Mr. Matang on my right.
Afternoon, colleagues. My name is Sandra Matlang from Eswatini Hospice Hub, Eco Coordinator. Thank you.
Afternoon, colleagues. I'm Pius Pungwayo, Bombo, Palliative Nurse. I'm based at Hospice at Home.
Good afternoon, everyone. My name is Ms. Melanie, the senior nurse at Hospice at Home. Thank you.
Thank you, Hospice team. Can we also have other colleagues introducing themselves? I will start from Malaika.
Hello, everyone. I'm Malaika. I'm from Eco India, and I am the executive at Eco India. Thank you so much.
Thank you, Malaika. Portia, can you introduce yourself?
Hi, everyone. I'm Portia Dlamini from Manzini Government Hospital. I'm with Nati Gunene, Semnumalo, and Enzwane.
Thank you, Portia, and your colleagues for joining us. Thandazile, can you introduce yourself?
Good afternoon, colleagues. I'm Thandazile Smelane. Yes, I'm Thandazile Smelane from Manzini Government Hospital, and I'll be joining with Nelson Mazibogo, our social worker. Thank you.
Thank you, Thandazile and Nelsiwe. Can we have Zamobuhle Kele?
Hello, everyone. My name is Zamobuhle Lukele from Eswatini National Cancer Control Unit. I'm the clinical focal nurse with Nomfundo Mjuli, our in-service officer. Thank you.
Thank you, Zamobuhle and Nomfundo. I don't know if we are leaving anyone out. Okay. Thank you for joining us once again, colleagues. For our previous session, we were looking at converting from short-acting to long-acting opioids. Please mute yourself, Thandazile.
Oh my word.
Thank you. As I was saying, last week we were converting from short-acting to long-acting opioids, and we were taken through by Dr. Smetlane from Manzini Government Oncology. So for today's session, we will be looking at prescribing practice and opioid conversion, and Mr. Matang will take us through the topic. So just a reminder, colleagues, may we have our phones or gadgets on silence? And can we remain muted unless there is something that we want to communicate? We can always use the chat box for any questions or comments. And we can also use the raise of hand if there's anything that we want to say during the session. So at this time, I think Mr. Matang can take us through prescribing practice and opioid conversion.
Thank you so much, colleagues. Thank you so much for the time we have today. In the past sessions, we've had great informative sessions that can help us to do better in our practices. It's so great that in this platform we are all learning. So today we'll be looking around on how to do the opioid conversions. It's just a build up on the previous session. Actually, in this batch, we are treating a series. So each and every presentation, it contributes to the next. So this one that we are covering today is from the previous sessions we have heard. So we encourage that we also go back to our YouTube channel to sometimes recap and get to know what has been discussed previously. And also previous presentations are always available in our iEco platform, of which all of us are registered in. So you have a 24/7 access to that platform if you are registered. So you can access those presentations that have been covered and cases that we discussed and other resource materials like the National Palliative Care Guidelines. But today we'll be looking around the opioids. How do we move from one opioid to the next? Last presentation, Dr. Smetlana advised that it is better to stick to one opioid, even if you are trying to put you try to use one for short acting. It's better when you're gonna use one type of opioid. So today we'll be looking, how do I move across the different types of opioids? So what are we going to, our goal today is that we'll be able to list the relative potencies and impact of long-acting opioids, and we'll be able to utilize best practices for safely converting from one opioid agent to the other, because those are the common things that will normally happen on the ground. And we'll also be able to account for incomplete cross-tolerance when changing between opioid agents. Actually, what we are going to do, we'll be looking around on how best we can swap from one opioid to the other. Maybe, and the reason, what is the most reason normally that may require us to swap that opioid. But then before maybe we go deeper to those things, let me just introduce these different terms that we need to understand when we are thinking of converting one opioid to the other. It is very important that you understand one thing, the drug half-life. Because one of the things we'll talk about, it's a drug clearance. So we need to understand when the drug will be cleared from the system. So this is the time that will be taken by the body to clear that drug from our system. So we need to know it. How long will that drug take time still within our system? If I'm thinking of changing one drug to the other. Another information that we need to understand, it's a drug potency, the amount or dose of drug needed to produce a particular response. How much do I need for this certain drug to achieve a certain response? So I need to also understand that before I'm thinking of converting the drug to another. And then there's this, what we call the very important area, which is, call it equi-analgesic potency. You know, so all these things, they help us to, it's not an easy move to move from one opioid to the other. So when we talk of an equi-analgesic potency, is the dose of one analgesic drug, is it equivalent to the other analgesic drug in terms of pain relieving effect? So, for example, I want to use morphine, but maybe the patient has side effects of morphine. Then I will look for another strong opioid of the same potency to morphine. So that's what we call equi-analgesic potency. So most of the drugs we are going to use, morphine is always the center, where when we are doing the conversions, we build them around morphine. So another term that we need to understand, it's tolerance. So, you know, sometimes we don't want patient to suffer from the drugs, but then there's what we call it drug tolerance. So a reduced reaction or resistance to a drug following its repeated use. So once a patient has used a different drug for several times, then they develop drug tolerance. So cross tolerance then is the very important issue you need to consider when you want to do some conversion. So which is the tolerance or resistance to a drug that develops through continued use of another drug with a similar pharmacological action. So if you are using a certain drug, then the body gains that tolerance, and then to another drug of similar class, then you'll find that then you need to consider those things when you are going to do conversions. So these are the terms we need to understand when we are thinking of conversion. That's why then we have these considerations whenever we need to do them, because we will, at some point in our care, we will have to cater for a drug tolerance or changing opioids from one to the other. But then we have how do I match the doses so that equivalent to the same effect. So the first one is that we need to switch from one opioid to the other. When we are switching from one another, we should only be recommended and supervised by a healthcare professional with adequate competence and sufficient experience. Actually, what we are saying here is that if I'm a nurse and I'm seeing that a patient is developing these side effects from this drug, but the drug is still producing the same effect, but then because of the side effect, I need to change. I better seek a specialist or who can help me do this conversion, especially when now the doses are too high. So we need to consider that one. So, but then it should be recommended. It cannot be done by the patients themselves. So we need to, it should be recommended after all the other things have been fulfilled. Also is that we need to consider that opioid rotation or switching may be considered if a patient obtains pain relief with one opioid and is suffering severe adverse effects. It's not just to change. It should be considered that I was using this opioid, but then the patient developed some severe adverse effects, then I need to change it so that I continue to achieve the same effect with less adverse effects. Remember that we need to balance the ethics, beneficence, malfeasance, and autonomy and all those things. So we don't want to increase harm on the patient, but we want to increase comfort. So we don't want the adverse effects. We know that some drugs, they come with double effect, but then we have to control those things. When converting from one opioid to the other, the initial dose depends on the relative potency of the two drugs and the route of administration. So if I'm converting, I need to know that it depends on the dose, on the relative potency. What is the dose of the other drug that is needed to achieve the effect and the route of administration? And then it goes back to the principles of opioid administration that we have shared in the past presentation, that we need to remember the best route of administration, especially pain medication. So also that one will be influenced by that. And this, we need to understand that there are conversions tables that have been provided. They are just approximate. And then these are from data from different studies that have been done. So, and we need to know that those conversions or tables that have been shared, they vary from individuals to individuals. So those tables that are there, we'll see it here, they are just a guide to guide us. This is how best we can do it. But then we need to know how that individual is reacting to that drug. I cannot say, okay, because you were not doing well with trauma, let me move you to morphine at this dose. You'll discover it is not working for that patient. So it should be individualized approach at always. So as we are talking about individualized approach when we're doing the conversions, we are saying that conversion factors are an approximate guide. So the fact that we need to know the dose and the route, those that's a guide that will help us to know how we can do better. Otherwise, studies that are still being done on finding the best way, but these are just approximation, and there's a lot of variation. An African differ, like Mr. Mvila once presented, that even how we react to certain drugs, we are different from how our counterparts, the Europeans maybe, will react to different medications. So it is very important that when you are going to do the conversions, you calculate the doses using morphine as the standard, then adjust to suit the patient and the situation. Remember, these are opioids. There are many opioids. We have discussed about them, but all of the opioids must be linked to morphine as a standard. How much will the patient receive? So it's like everything must pass through the morphine standard, but we will see how best and we can do it. In most cases, when switching between different opioids, the calculated dose equivalent must be reduced to ensure safety. You know, the patient will react differently to different drugs. So if I'm switching from morphine to tramadol, I need to reduce the drug, or I'm switching from morphine to methadone or another drug, I need to reduce the dose I'm gonna give the patient. Or I'm moving from tramadol to morphine, I need to start a little bit lower when I'm starting the morphine, because I need to check how is the patient reacting to the drug. That's why Dr. Smetlana last session said, no, it is better to use drugs of the same type, because if it's morphine to morphine, it's better because you have the base or information on how is the patient reacting. But then if you are then moving from one different drug to the other opioid, we are saying start from with the lower dose, and then you will titrate as you go up, and then you will see the patient, how is the patient doing. And also, if you are moving from a less sedating drug to a more sedating drug, it's better to also cut the drug to a lower dose so that you can see how much the patient will be sedated. And then you will titrate slowly so the patient will accept that dose. So when you are moving from one different to the other, you need to know even the qualities of that drug. Another issue is that a dose reduction of at least 50% is recommended when switching at high doses, like oral morphine or equivalent doses of 500 milligrams in 24 hours. If I'm switching, the patient has already taken a higher dose of the drug. So if then you are switching that higher dose already, you need to then at least cut it half so that the patient can now accept it. You will see the conversion that sometimes another dose is very high. If you are moving from morphine to another drug, you'll discover that the potency requires you to have a higher dose of the other drug. Then you need to cut it by half when you are starting so that the patient can accept it, especially our elderly people and frail patients, because sometimes baba nema intolerable and undesirable effects from those drugs. So you need to monitor them. So in such a way that other drugs, it is recommended that when you are doing the switching or conversion, you admit them and then do the conversion and see if they are responding very well to that drug, then you can discharge them home. Let's also emphasize what Dr. Smetlane emphasized even last week, that when we are giving opioids, we need to be cautious of renal for clearance and the liver for metabolism of that drug. And most of the opioids, all of them, they require that the patient have a good renal and a hepatic failure. There are those that may work well when the liver or the renal is not good, but they can then be given as a replacement. But in our context in the country, we are using more tramadol, morphine, and other drugs. These drugs that we are using in the country mostly, they require that the renal is working well and the hepatic is doing well. So that's why then you will discover that this test needs to be done, as Dr. Smetlane advised, that sometimes those tests need to be done as a baseline to know how is the patient doing. So we need to calculate and remember those conversions. Don't move a patient from a drug that is don't move a patient to a drug that is too dangerous to the liver and to the renal when it is dangerous. And so better look for another drug that will be safer for the renal, because that one is very good. That is what is very important for the patient to do well with the drug. Then when we are prescribing, it is very appropriate to prescribe an appropriate dose of rescue PRN medication. Last session, Mr. Smetlane emphasized this, that when we are giving the long-acting medication, we also have to prescribe the short-acting for breakthrough pain and management. So we need to give them, those are the drugs that we give them for PRN, because they will be then used for PRN reasons, especially when there's a breakthrough pain. Like I will give you the morphine MST tablets, and then I will give you a liquid for breakthrough pain. So in the country, our national palliative care guidelines recommend that when we are giving morphine, you will give a 1/6 of the total daily dose of that patient. So if the patient will be getting morphine 5 milligram, so the patient will be taking 30 milligram a day, then a 1/6 of that one, if it's taken by 4 hours, it will be a 5 milligram liquid. So if the patient was taking a 15 milligram MST tablet, taking morphine 15 milligram to BD, And then it means it's taking 30 milligram BD in a day of the MST. Then I will prescribe the short-acting or the liquid morphine, 5 milligram for breakthrough pain. So that's what we need to do, even when we're doing the conversions. Remember to have that drug. So others will recommend maybe a tenth of what the patient is taking, so as a breakthrough pain. So we need to remember that we prescribe maximum hourly so that patients do not have to wait for the rescue analgesia. So we need to provide the correct hourly time. There's nothing like PRN when you're prescribing a background dose for opioids. We have discussed it many times in our previous sessions, so we need to remember that. So the half-life and time to onset and action of the two drugs when we are converting need to be considered when converting so that the patient does not experience breakthrough pain and receive too much opioid during the conversion period. Maybe make an example. I have a drug that lasts for 3 hours in the body, and then I have to prescribe another drug that will take an hour to act. So it means I need to be careful when I am prescribing that drug, because if I'm going to give the patient a drug that will last for 3 hours, then the other one, if I give the patient, will take an hour to start. It means the patient will have some time without a medication in his blood, then he might suffer pain in that period. So I need to know how long will the other drug be cleared from the system to avoid overdose. And then how long will this drug I'm prescribing will have an onset of action. So we need then to balance those two things when we are converting. Like moving a patient from short-acting to long-acting, I need to know the other drug will take how long to action, so that then I prepare the patient for that time. That's why then we say start small and grow as you go up. So once the conversion is okayed, the dose of the new opioid should be titrated carefully according to the individual's response, and the patient be monitored closely for side effects and efficacy, especially when switching at high doses. And so we will use the same principles Dr. Smetlana shared when we were looking at monitoring opioids and efficacy. So what we are saying that, though in the country I've never seen them, but we cannot say then we put a blind eye, because we have clients who go to South Africa and they receive different opioids, maybe sometimes that we have in the country. Some will have that enough money they can procure. We have what we call formulas, especially morphine formulas and other opioids that comes in patches. So they just go through the skin into the person. So when we are going to do a conversion, so avoid to use the patches, because if then the patient is using patches and is converted, patches take some time to be absorbed. So patches are good for like sustained release, so they will take time. So you cannot use them. So you avoid them, especially with patients with unstable pain. It's like with people with we are not sure how much dose they need for control of pain. Then you cannot move that patient to a long-acting dose if you are not sure of how much the patient needs. So you need to stabilize the pain with the short-acting. Once you have reached the maximum dose that is required to control that pain, then you can move that patient to the patch or that long-acting dose. So you need to remember that. So sometimes for parenteral, it is recommended that we go for subcutaneous route. But then we need to be very cautious of the withdrawal symptoms like sweating, yawning, abdominal cramps, redness, anxiety, because they occur in opioids, as we have been shown. And if the dose it's been stopped abruptly and they are more severe, so that's why then in opioids, then we have to have a way of going step down when we are withdrawing certain drugs. So these are the steps, these are the things we need to consider when we are thinking of changing an opioid. But remember, if I'm not sure, I need to engage a specialist or one with an experience on how to convert those drugs so that I don't harm the patient, because these can have detrimental effects if not done very well on the patient. This is just a diagram that shows how the equivalent opioid drugs looks like, and it shows the conversions, how they move. If you look at this diagram, at the center of every conversion, there's morphine. So there is no movement from codeine to trauma that's moved like that. You always move through morphine and then you go to that track you are looking for. So all the conversions, the center of all opioid conversions is morphine. So I will look at, if I want to move from tramadol to morphine, I go via the conversion to say, what is the equivalent of tramadol and morphine? Or I want to move from tramadol to fentanyl, I will go that way. I want to move from tramadol to codeine because of certain reasons. I move through morphine. I just don't convert from tramadol to codeine. I move through the conversions. If then I'm moving this way, how will this relate to the other drug? Then your calculations will tell you how much dose you will give to the other person. And remember, you don't convert because it is not working. You convert because it is working, but with adverse effects. So it is working, but it is producing some effects that are not needed from the patient. So I need to convert to another one that will do better maybe for the patient. So this is the table that we need to know. But remember, always go through the center of the chart, which is via the morphine, the oral one, not the injected, but the oral morphine, and then when converting the opioids. So that one is very key. So these are just conversions adapted from the WHO guidelines for pharmacological and radiotherapeutic management of cancer pain in adults and adolescents, published in 2018. So in these guidelines, I've just sampled these ones, so that are most common to us. So if then I'm looking the potency of codeine to morphine, it is 0.1 milligrams. What does it mean? Codeine will last 3 to 6 hours. So if then I'm converting from codeine to 10 milligrams of oral morphine, I will need, if I'm converting from 10 milligrams of morphine, I want to give codeine, I will need 100 milligrams. So 100 milligrams of codeine is equals to 10 milligrams of morphine. So that's how it is. So even tramadol is the same, but look at the timings, 4 to 6 hours. So if I'm converting tramadol, if I want tramadol for morphine 10 milligram, I need 100 milligram of tramadol. So that's how you do your conversions. So you need to know the potency relative to morphine. How much is that? So in short, that's how you convert it. So let's look maybe a table that has been summarized that is so clear that you can also reference, that was taken from Wexner's Palliative Care Physician's Handbook of Palliative Care, the 9th edition of 2019. So this is one of their chat box. I will just sample morphine. If a 4 allele dose of morphine, you start from the lowest dose, which is normally 1.25 milligrams. That's the lowest dose. Even if the patient is breathlessness, if they say give the low dose of morphine, if they've never stated how much, the lowest is 1.25 milligrams. Then in a 24-hour, you'll have 10 milligrams of morphine. But then look at 10 milligrams of morphine is equivalent to 100 milligrams of oral tramadol, and it's equal to 100 or 120 of codeine phosphate. So if then I'm converting, I need to know, I have a patient who is taking tramadol 100 milligrams, but then he's getting adverse effects and I don't have codeine. But then I want to give the patient morphine. So if the patient is experiencing tramadol adverse effects, I need to give morphine because that's the best drug I have. Then I will go straight to see 100 milligram of tramadol is equals to 1.25 milligram of morphine per dose in each 4-hour session. It means I need to prepare a 10 milligram of morphine for that patient in a day. Then it will depend on, it's either I need an MST that will give me 10 milligram BD, or I will need a short acting that will be liquid, that will be given every 4 hours, which will be equal to 1.25. So most of the time, you will find that we have a patient in the field or at home was on morphine, and I don't know what to give that patient. So now I can convert from morphine to tramadol and tramadol to morphine. But if you look at tramadol, if I'm moving from tramadol to morphine, you can tell that there's a limit of tramadol. Morphine that is equals to 60 milligrams in a day cannot be converted to tramadol at all. Because if you convert morphine 60 milligrams to tramadol, it will be more than 400 milligrams a day, which is the limit of prescribing tramadol in a day. So we need to be very cautious then if we are converting, because we don't want the patient to have pain, but then we don't want to exceed the maximum limit of the day. For example, codeine and morphine, they go for a short period. Once you reach 240 of codeine, we have hit the ceiling of codeine, and then you cannot go that much. Maybe we have a patient who has already on codeine, but then we are scared that might develop a problem, but the pain is still escalating. We move to another drug, high dose of morphine. So this one also will help you to know the starting dose for the other drug that we are expecting the patient to react or to develop a good effects of the drug, or will have a good outcome of using that drug. If my patient was using a codeine 240 milligrams and then it develops some adverse events, then effects, then I have to convert my patient to morphine. I know I will start my patient maybe at 2.5 milligrams or 1.5 and then titrate slowly, but I'm expecting that once my patient reach 2.5 milligrams, I should receive the same effect that I was receiving from the codeine. If my patient was taking tramadol 400 milligrams a day, if then I'm developing adverse effects, I'm going for morphine, I will start a little bit lower, but I'm expecting my patient to give me a better effect if I'm giving 40 milligrams a day of morphine. So that's how you do the conversions. Maybe I will say this is what we can say about it, but for further reading, you can have these sources to get information on how best you can do it when you are doing the conversion. So maybe that's what we can share in terms of converting. But remember, apply all the principles we've been sharing from the previous presentations when also you are doing the conversion. Thank you.
Thank you, Mr. Mashamo, for such a lovely presentation. I believe it was audible to all of us colleagues, and I want to believe that we're all able to get something that will help us as we prescribe and convert opioids. So at this point in time, colleagues, I will give us or open an opportunity for anyone that wants to ask a question with regards to the presentation or any comments or additions that we might have. So we can use the chat box to ask a question, or maybe mention the comment, or we can also use the raise of hand.
Maybe to add, last week we had a question from Sister Spongile who asked if when we are in the ground, then the patient was on morphine, and then now there's no morphine, and we don't know what to give. After the hotel advised that we need to stick on the same drug. For example, if my patient is on morphine, it's better to always give either short or long acting of the same drug. So if it's morphine, maybe the patient was on MST morphine, 30 milligram, but now, or 20 milligram, which is the most common formula that we have in the country currently, is being given BD or 4 times a day or whatever. And then now I found that I'm there and I'm a clinician, he's the patient, and the morphine is out of stock. Then the question was, what can I do? Because I cannot keep on switching. And it is true. We cannot keep on switching the patient on opioids, because then they have different tolerance level, they have different effects, you know. So we have to stick to one that we have known to give the desired results that we want from the patient. But then I think from today, now we can see that we need to know the conversions. If now this is the case, how then do we move the patient? But then it is not recommended to convert patient this side and this side, because then they end up developing adverse effects. There was also a question in terms of the availability of morphine last week. So unfortunately today, even Sister Felicity couldn't make it due to other commitments. But she did give the response that morphine in the country is readily available, and it's most of the time found in Babane government, where it is being made. So it's the duty of the different facilities to ensure that they go and collect it. Currently, we have the collection problem in the country, whereby we find that facilities are not collecting it. So I think we need to encourage one another to go collect it, so that the statistics can be clear, and so that maximum order can be made with the medical stores in terms of getting the powder before it is reconstituted, especially the liquid one. Also, the morphine is available. It's an issue of prescription and the collection that we need to deal with as healthcare facilities. That's what she said. Maybe to add on that.
Thank you, Mr. Mashamo, for clarity on those issues. I don't know if we are leaving anyone behind, colleague. Anyone that wants to add or ask a question before we move to our case presentation for today's session? In the interest of time, I think we'll move to our case presentation, but if there's any questions that maybe you have, you can still use the chat box. You can use the chat box to indicate any question or comment that you have. So we have Paz Puayo, our Lubombo regional nurse, who will present a case for us. Over to you, Paz.
Good afternoon once again, colleagues. As I've been introduced, I'm Pius Puayo. I'll be reading today's case on behalf of Mbabane Government Hospital. So our case today is about the 51-year-old client. Diagnosis is thyroid cancer, stage 2 with compression effect. The problem or concern about this client is goiter tumor compression jugular vein, compressing jugular vein, trachea and meningitis due to the lung noted, and the client experiencing severe pain. The concern here is blockade of the airway if initiation of treatment is delayed. Holistic assessment. Chief complaint, growing mass accompanied by severe pain, on and off difficulty in breathing and eating. Then there is a hoarse voice. The duration is 2 years. On assessment, the client is sick looking with loss of weight and a visible mass on the right lateral side of the neck. Reduced ability to do physical activities, now in bed most of the time. Pain assessment using the PORST. The duration of the pain. Okay, the first pain's duration is 3 months. The character is pressing. Numeric rating is 4. Periodicity or constant. Or periodicity, the pain is constant. Precipitating factors, it's heavy weight of the mass. relieving factors, medication. The pain affects sleep and it also affects mobility. Effect of current medication is partial. So there is also another pain, whereby its duration is 2 years. The character of the pain is pulling and pressing. Numeric pain rating is 3. Periodicity is constant. Resuscitating factors sleep on the same position. Relieving factors support body with cushion. Also, this pain affects sleep and mobility. Effect of the current medication is also partial, even with this pain. Pain evaluation. The pain evaluation, the duration or days, weeks, or months when evaluated, the pain on evaluation, pain location was on the right neck. I think on the first assessment, which was on the 22nd of February 2023, it was on the right side of the neck, whereby on scale it was 4/5, intensity was severe, the duration was 3 months, possible cause was the mass. Treatment for this pain was morphine solution, 5 milligrams, 8 hours. So I presume it is the very same day the other pain was on the neck and shoulder, which was rated to be 4/5, which is moderate, and the duration is 3 months. Possible cause is also the mass. Treatment is dexamethasone, 4 milligrams IV. Progress following intervention. The client was initiated on strong opioid oral morphine, 5 milligrams, Noctare, 2.5 after assessing the severity of the pain. And since weak oral opioids, tramadol is not available, so it was from step 1 analgesic ladder to step 3, which is strong opioid. A relative reported that the patient was still experiencing severe pain when asked how often the patient was getting morphine. Response was 3 times a day. A health education on morphine use was offered on the 27th of February 2023, and on the 31st of February, a relative reported that the client is now relieved of pain. The pain is intermittent with score 3/5. The dexamethasone reduced the inflammation and the pain, and the patient is calm. She was able to sit on bed with less difficulty in breathing. However, still complaints about the heavy weight of the mass was pulling her. Hence, she spent most time on bed. Medical or surgical history. Medical history, the patient is diabetic and she has type 1 diabetes, and he is also hypertensive. No surgical history performed. No operations performed, meaning there is no surgical history. Medications. Relevant past medications. The patient was on paracetamol 1 gram TDS and was also on diclofenac 50 milligrams. Currently, the patient is on oral morphine solution 5 milligrams 4 hourly plus bisacodyne, prednisolone 10 milligrams OD, metformin 850 milligrams BD, and HCTZ 25 milligrams PO. Social history and pertinent family history. Work status, the client is unemployed. Occupation, she was a housewife. Education, secondary level. Socioeconomic state, socioeconomic class, the client is middle class. The client is married. Lifestyle habits, church activities. Relevant health conditions in the close family members. Sister, I guess it's sister of the client was done thyroidectomy in December 2022. However, biopsy was not done. Advanced directives. Okay, there's no living will that was drafted. Advanced decision to refuse treatment, there is none. Healthcare probes, there is none. Mental capacity was assessed. Comments or concerns. The client is stressed by the delaying of referral process of Palala Fund SA for chemo and radiation therapy. Review of systems. Vital signs. The temperature was 36 degrees Celsius. BP was 122/78. The pulse was 108 beats per minute. Respiration was 24, and saturations were at 93%. The pain score on assessment was 8/10. ECOG functionality score. Sorry. Okay. The ECOG functionality score is 2. Then when we go to the assessment of pain, so assessment of other symptoms like pain was 4 on scale. There was dyspnea, moderate. Anxiety was moderate. Agitation was severe. Depression was moderate. Drowsiness or fatigue was moderate. There was no nausea or vomiting. Anorexia was moderate. Constipation, there was no constipation. Focused investigations. The labs. Hemoglobin was at 9.6. Also, imaging or special investigation test done was chest and abdominal CT. On findings, there were cancerous tumor, displaced trachea, carotid and jugular vein with metastasis to the lungs. Further plan. In the patient care plan, pain management, maintain morphine dose of 5 milligrams for hourly and monitor for side effects and keep morphine by the side local or relative to give it to her as prescribed. Health educate the patient and family about the use of hands to communicate in order to reduce straining of voice and taking of tolerated diabetes or soft or liquid diet. MDT approach. Constant follow-up with the Palala office for the referral to SA. Referral to surgical team for possible intervention to create temporal surgical airway. Oncology and ENT for possible treatment options and follow-up care. Counseling of patient and family. Palliative care team to reassess, review clients' needs, counseling, network with MDT. Linkage. Fill referral form to link patient or family with hospice team. Spiritual care to strengthen faith and spiritual upliftment. Family conference, supportive with life-sustaining procedures, financial, emotional, child welfare. I guess this marks the end of the case presentation. Thank you very much for lending us your ear. I think at this juncture, we can allow for additions, advice, and recommendation.
Thank you, Pat, for the presentation. I believe, colleagues, we can tackle on the case of the client, even in absentia of Sister Felicity from Bolani Government Hospital. And probably for some questions that we might not have answers for today, we promise to bring feedback in our next session. So if there's any questions we have about the case, any comments or any recommendations on how the client can be better managed, this is the time, clients, to discuss that. We can use the raise of hand and we can also use the chat box. Are there any questions we have on the case or any recommendation?
Maybe because today we have Nurses Zamo, he can help the team to understand. Maybe she has the information concerning the process of Palala to South Africa, and here we are told that the patient is a female, aged 51, with a cancer on the goiter tumor or thyroid cancer, which is stage 2 there. But I saw somewhere along the line written lung metastasis. So I don't know how they say stage 2, if it's metastasizing to the lung. No, maybe she can share any information, if possible, in terms of the logistics, in terms to South Africa. What usually the physicians look to consider for a patient to be taken to South Africa. It's unfortunate Felicity is not here, but one of the things I think will be considered here is the patient plan, because now the patient is frustrated. The process is still taking long. I don't know if Zamo will advise in terms of these issues, in terms of the referral to South Africa, because it's like the patient is frustrated that the treatment is taking so long to go to Palala. If there's anything, because I'm aware that the NCCU has something to do with in terms of patient treatment. I don't know. Sorry to put you on the spot, Zamo.
It's okay, Mr. Mahlangu. What I know is that, okay, I think there was a problem with the staging. I don't know how the colleagues feel, but I think there is a problem with the staging if stage 2 and then there's metastasis. There is a problem. And then concerning the Palala issue, last month we had a presentation from Palala administrator who said that they have hiccups in terms of the funding. their financial year currently, they don't have funds. I think that is one of the problems. The process is delayed. And yes, I think that is it. And the other process is that you have to go to the board for approval, and then you get a visa for transfer to South Africa. It's some of the hiccups that happen along the way. But we are hoping that those problems, as soon as they receive funds for the quota, some of the problems will be sorted. Thank you.
Thank you, Susan.
Thank you, Zamo. I don't know if there's any other questions, colleagues, but I think she has actually given us clarity on the issue of Halala. Do we have any other questions or comments on the case? Seeing a hand from Magel Zodwa.
Okay, thank you so much, Tim. I want to appreciate the presentation and the plan that the team has for the patient. According to what I heard, I think they have a comprehensive plan and it seemingly meets all the needs of the patient if they get to be implemented. So I'm just appreciating the plan that they have put in place for this patient, and we hope for the best as they try to implement the plan. Thank you.
Thank you.
Thank you, Maggie.
Please.
Do we have any other questions or comments? Colleagues?
Maybe my addition to such a patient, there's somewhere where sister said monitor side effects. When a patient is given the opioids, in such a case whereby already we have a patient who is a pushed trachea and difficulty sometimes in breathing, is one of the things we will have to monitor closer when we are giving the opioids, because we know by nature the opioids depress the respiratory center. So when you are prescribing such opioids, you need to be very cautious of the respirations. Every time you will meet such a patient, first thing that you may not skip at any moment is assessment of the respiratory system, because it's compromised by the tumor that has already metastasized to the lungs, and also it's compromised by the closing of the trachea, by the suppression of the tumor. So you see there's a double stress here that needs to be catered for. So then if you're adding an opioid on top of that, you need to also monitor that one very close. So whenever you have a patient who has difficulty in breathing and is already on opioids, one of the things you have to be very cautious of, it's oxygenation and supply to the patient in terms of the respiratory system. You need to check that one, not letting go the other issues like circulation, blood, and other issues. So I will say that whenever as a team we meet such a patient, let's look closer to that one, because we need to monitor even the dose of the opioids. If then they are suppressing, then we need to intervene as quick as possible. It's so great that another thing Babane government said they will do. I think another thing they need to do here is to find out with the feasibility of the treatment too. You know, because we might keep Palala. We have seen patients kept for a long time on Palala, and it finally ends up not happening. And then you find that the family members end up with anger. I think the issue that Zama was saying needs to also be shared with the patient, so the patient can know. But then again, is the feasibility of the treatment. You know, it can be painful to take a 51-year-old woman to South Africa with different goals from the team. So I think also those goals needs to be discussed. I think one of the things they need to discuss is the goal of care with the patient while we are still pursuing through Palliative, so that maybe the families will then understand if they still continue with South African treatment, because they need to know why do we have to go to South Africa with the lung metastasis and the tumor. Maybe you'll discover that's just radiation of the tumor, then what about the lung? So I think also that also will help the patient in terms of understanding really what they are looking for. Yeah.
Thank you, Mr. Masangu. There's a question on chat box from Tandazile, which says, may we kindly check how the client feeds? If she has difficulties, have we considered referring to the dietitian as well? I think that's a very important question that we probably haven't taken note of, but I think we'll share it with Sister Felicity so that we get more information and clarity on how the client is feeding and what other options have they probably exhausted in trying to meet the client's needs holistically. I think we'll give you that feedback on our next session. I'm not sure if we are leaving anyone behind, colleagues. Still tackling on the case from Bamani Government Hospital. Whilst we are still waiting on that, can we kindly click, there's a feedback link that has been shared on chat box. So can we kindly click on that feedback link so that you can give us feedback on how today's session went.
Okay, maybe to understand this, Tadazil is a question. Is the client aware of the staging intent for treatment? Yes, that's what I was trying to say, that I think the client needs to be informed of the diagnosis. I'm hoping it's just that Sister Felicity made it not clear. If they are aware of the staging, they understand what does it mean is the metastasis and how far is the lung affected, so that the benefits and the beneficence level of the treatment can be weighed on the patient, so that we don't give the patient false hope in terms of, okay, your life is now dependent on Palala. Yet you will discover that even Palala will take you to South Africa, but you will still have to go through this. So I think that one also needs to be discussed with the family. It's unfortunate that we are seeing stage 2 with metastasis. So that also needs to be cleared very well with the patient. What is happening here? We have seen patients who have cancer, and then maybe they've missed the metastasis part, and they are cleared of cancer, but not very long. Now they have metastasis, and it's so hurting to them. So I think that also the MDT needs to consider in terms of getting to know the diagnosis very well and having on board the family. And it pulls us back to the issue that I think the plan of care needs to be developed because this is a critical stage for her. And, living with a person with respiratory challenges is very difficult because there's pain, there's respiratory problems. So I think maybe in our next session, because we'll be still looking around the conversions, in such patients also, you will discover that the morphine is becoming more challenging in terms of taking food or even swallowing. But I'm happy that Sister Felicity, in terms of diet, they've put in place that they will encourage the issue of taking fluids because of the swallowing of the tumor. So we are hoping still the liquid morphine is working for her because the MST might be a challenge maybe to swallow at this point in time when the tumor is pressing. In my experience in the field, I've met different patients with with thyroid cancer or with different tumors that suppress the GI system. And then you will find that it becomes very challenging to swallow an MST medication. So they will rely on fluid. Then it gives us back to say, ethically, then we have to focus to the treatment that needs to help the patient. So I think here you'll find that we are working on the MST for such a patient to help deal with the pain. But then for food, it's also gonna be the soft meals. But then the family needs to be educated also in terms of what are the possible progressions that might come out of this progression of disease, so that you can prepare alternative feeding measures while they are continuing and understanding how to handle those difficult times that might show up from these challenge. So that's what would be my contribution to this case. But I'm hoping, because there's a lot of referral that's going to happen from this case, so we are hoping we'll see the hospice team will take on in terms of the family counseling and stuff. So we are hoping a patient will be taken care of while she is still with us as a team.
Thank you, colleagues. Thank you for your participation and recommendations. This is actually a platform where we are able to share relevant information and we are able to discuss issues that we actually face on the ground. And this basically helps us to improve our practice and the well-being of our clients. So we really appreciate it whenever you join the sessions and whenever you are able to share information with us or those recommendations. So can we kindly click on our feedback links for those that haven't started, so that you can be able to get the feedback for how today's session went. We have come to the end of our session, but if there's anyone we are leaving behind, feel free, you can still raise your hand or write something on the chat box. Our next session will be on the 22nd of March, and we will be looking at advanced conversions and opioid side effects. I hope I'm not leaving anyone behind, colleagues.
Today's presentation will be available in our IECO platform at around 3 p.m. So if you wanna go back to read, you will find it there in our platform.
Thank you, Mr. Matamu. Thank you, colleagues. I hope you will have a good day. This is it from the hospice team. Thank you.
Thank you, everyone. Bye-bye. Please remember to click the IECO feedback link before you exit.
Thank you. Bye. Thank you for the lovely presentations.
Thank you. Bye-bye.
Thank you.